There we go. Looks like we are ready to go. Hello, everybody. I am Alexa Tinsley. I am the Director of Programs here at Jet Foundation. I want to thank you all for coming today. We are learning about transition of care, and I've actually seen this deck, and I'm very excited for Dr. Kesselman and Dr. Zelikovic to be presenting today. Just going to go through a few housekeeping items before I hand it off to them. We are recording this video, so if for any reason you need to hop off, or if you know someone who wanted to watch this webinar and wasn't able, or after and you've gotten all this amazing information and you want to share it with others, it will be recorded for you guys to share. There is also closed captioning at the bottom of the screen. So on my screen, I have to click the More button, and then it has a CC show captions option. You can do the full transcript, or you can do captions as well if that's something that you would like. At the end of this presentation, we will do a quick Q&A. We do primarily use that Q&A box, which is also in my my little More bucket, little box with a question mark in it. So that's primarily where we will go to answer questions. We are streaming to Facebook, so we do try to monitor that as well and try to monitor the chat. But if for some reason we don't get to your question, you can always email us after, and we will get them to Dr. Kesselman and Dr. Zelikovic to try to get you answers after. So with that, I'm going to hand it off to them. Thank you guys so much.
Thank you all so very much for having us. So there are obviously two of us here today, and that is because for a transition of care, we are talking about transitioning from pediatric to adult care. So it's, I think, a little unfair to really do justice to this topic without people who are experts or have expertise in both of those sides of the transition. I'm Dennis Kesselman. I am the director for our pediatric neuromuscular program in Westchester County, New York, formerly through Boston Children's as Boston Children's Health Physicians, but really my affiliation is with Westchester Medical Center or Maria Freire Children's Hospital. That's part of New York Medical College.
And my name is Dr. Aaron Zelikovic. I'm an adult neuromuscular physician scientist, really interested in transitions of care from young adults to adult clinics and really helping make that a better experience and providing the high level of care that you get in pediatric clinics to also happen in adult clinics as well. So really excited to be able to partner with Dr. Kesselman and be able to provide some insights and share our experience and expertise with all of you in the Duchenne community.
So I'm going to take away about the first half of this talk, and then Dr. Zelikovic is going to kind of take it away for the second half in parts. Here are some words on a slide, and here are our objectives that we hope to be able to give to you. And really, we're going to talk about transition of care in all sorts. And this is a topic that is getting a lot of attention lately because we are realizing that there are many faults and many different ways that people can slip through the cracks and that we can provide unequal care and unfair care as you start to get older. Our audience certainly knows this, that Duchenne is progressive and the needs do shift by stage. So in the early aspect of it, we're so focused on the baseline assessments, family support. Then we get into starting corticosteroids, motor planning, motor monitoring, physical therapy. All those become very important. And then as time goes on, we almost shift our lens a little bit to looking at the big picture, the global aspect. So those are scoliosis monitoring, cardiac monitoring, respiratory, bone health, and then we get into more assistive therapies. And we talk about transition of care because to be frank, the natural history of Duchenne has really changed over the years. And so before before the 1970s, the age of diagnosis was 6 and up. And now it's really getting lower and lower. And with the introduction of newborn screening, it's going to be even lower. And so that is one reason why the natural history has changed, is that we have more time to be able to do things and to be able to prevent complications of the disease. But then there's also all sorts of different other things that are leading to longer survival, thankfully. So those are steroids, cardiac medications, ventilation, and now other therapies that are on that are in the realm of possibility. So the result is that we have a growing adult population who needs well-founded, coordinated lifelong care that encompass all the different specialties that we in pediatrics are so used to including. And here's another graphic that is kind of showing the downstream consequences of all of these things that we're doing, which is that survival is now really possible well into adulthood. And these are numbers that are really underestimating what people today are experiencing. Before the 1970s, the mean survival was about 18, and now it's getting higher and higher and higher. And the latest official number is that for those that were born around 1990, the average survival is about 24. But you may also know that this not, it's only 2026. And so this is an incomplete number, but we are clearly getting at least a gain in median survival of about 6 years. And there are many patients who are living far beyond that, thankfully. And so 30s and beyond is very common now in many patients with modern coordinated care. So transition is really not the same as transfer, right? Transfer is a one-time thing. It's, well, goodbye now. You're now 18 or you're 21 or you're 25 or whatever age we are putting as a line. Go see this adult team. That's a transfer. That's a single event. And it says, well, as of right now, you are pediatric and tomorrow you're adult. Transition is really a years-long process that takes time to build up, and it's looking at the big picture, and it's thinking, 5 steps ahead of how is this going to look 10 years from now. And so that is what we're talking about today. It's transition of care, not transfer of care. So transition of care, you can understand, looks a lot cleaner and it looks a lot better for the patient and the family compared to the transfer. And that's really what we want to aim for. Let's talk from a pediatric perspective. So transitioning from our perspective, as a pediatric neuromuscular doctor, transition of care is hard for me to do for many different reasons. One big one is that sometimes I personally don't want to let go of the patient, but also it can be really hard when for the last 18, 20 years, name it, you've really gotten to know a family and they've gotten to know you. There are not many adult neuromuscular specialists that find themselves really excited or really confident in the new therapies and the new research that's happening with Duchenne. And so that workforce is building. And so often your pediatric neuromuscular neurologist has a trusted companion that they know is going to take care of their patients very well and is up to date on everything. The pediatric care coordinates many specialists around one family, and it often shifts in the adult world. Not always, but this is just often. It shifts to coordination onto the patient. So now the patient has to figure out, okay, when do I see endocrinology? How often do I need to see them? I need to go in a separate day for that, cardiology, pulmonary, neuromuscular. And so it's a little bit fragmented in that way, or it can feel that way, at least from my end. Life demands, obviously, things start competing with each other. So school, independence, responsibilities, and then emotional readiness is a big component of this that I don't think we can ignore. That sometimes it just feels like letting go is hard. There's broad recommendations that are in the literature already about transition of care. So when you go into the literature, there are many different papers, many different guidelines that say, how should transition of care look? What should happen in it? And where does it go wrong? The literature is helpful, but it's not real world. And we can pretend like it is. And for some of this talk, we will pretend like it is the real world. But then we're going to go into how does this actually change once you introduce the real world into this. And so these are all the different parts on the screen, all the different parts. Hopefully you can see a cursor of the transition of care that we have to think about. So relationship with others to housing, transportation, healthcare, activities, daily living, and education all need to be planned for. There's many different kind of guidelines, and here are the different years for them. The first really came out in 2018 as part of the DMD care considerations, a big guideline for DMD care as a whole. And transition was featured in terms of that to make sure that the lifespan is addressed and not just the pediatric and not just the adult world. And we kind of go on from there. And there are many different panels and many different papers that talk about this, and we can kind of break it down into different important steps. So with with goals of transition, what everyone agrees on as a commonality is that we need shared objectives. That makes sense, right? We need to be on the same page all at the same time. We need to talk way ahead of time, way before a patient becomes an adult, about what may this look like, what might a good transition of care look like one day. We really have to prepare everyone. We have to actually, we as the pediatric providers have to initiate a process rather than just let you go. There needs to be a summary, a good handover document from us. There needs to be good content within that document. So not only the big picture, but the details about what steroids was a patient on, why did they switch from one to another. You get the whole idea. The first adult visit is really a patient-led first encounter. It's a meeting. It's really like a date, rather than, oh, let's go into all the very specific granular details. And then we need to essentially make sure that that transition has completed successfully. We're still struggling a little bit because of all the things I really talked about. And really, in the interest of time, I'm going to summarize this as a few words, which is that we often think of transfer as reactive instead of planned. And that's what we're trying to change here. And as you can see here, that it really does begin with the family for all the reasons I talked about. A good transition of care comes with the family advocating very well. And so by age 12, ideally, we should be thinking about this. And this is all about awareness. So by age 12, we really introduce the patient, the boy, into the conversations to be aware of where is this going. A couple years later, or a year or 2 years later, it can be, this is suggested, we can really start letting the patient be the main person in the room as they always were, but make them feel that way. So they're the ones who are asking the questions, who are answering the questions if they can. And we're going to talk about how we reach our goals for the year. And then as we get more into that adolescence and later adolescence, it's all about learning the specifics, knowing the doses of your own medicine, your own history, the own medication names, and really advocating for yourself. Because very soon that patient's going to be an adult where the adult infrastructure is entirely based around the patient knowing their own story and knowing what worked and what didn't know and what didn't work. Then we have to identify an adult team, and that's what we talked about earlier, and then actually complete the transfer. And all of this can be shifted based on the center. So there are some pediatric neurologists who feel very comfortable managing a patient with Duchenne muscular dystrophy through their 20s, sometimes even into their 30s. And there are some where 18 is a firm cutoff and everywhere in between. So it is based on in a way, the protocol and the culture of the system and the comfort of the individual providers. And not only that, I didn't just mean pediatric neurologists. That was an example. Also, pulmonologists, cardiologists, you name it. So everything is kind of built around a team. Here's just a diagram showing the same thing. There is this transition toolkit that I find actually very particularly helpful. This is a published paper in the Pediatrics Journal, or the American Academy of Pediatrics, their journal, back in 2018, that I only put in 2 pages, but it's a several-page document that is really helpful for us as well as the family to keep track of what is going on in the global care of this patient with Duchenne muscular dystrophy, and what are the steps required to be able to do a very good transition. So you can see here that this is a transition readiness document that I've put up. This is directly from this paper, and it's publicly available, and I personally use it, where it kind of goes through many different questions. So I know how to tell my doctor's office about the special assistance I need before my visit. Like, I need help to get out of my chair, and you can check off, I need a plan, I need to learn, or yes, I know this. And by the end, really, when you're ready to transition, a good transition is, yes, I know this on everything. And then it's, yes, I know my plan about everything here from a respiratory perspective, from a vertebral compression fracture perspective. I know everything that's been going on. Um, that's an ideal world, right? Ideal is the main word here. There are several skills to know in order to master to really be able to have transition readiness. So all of those things are just a form, but the big picture here is patients should have some health knowledge, medication management knowledge, appointments, know how to make them, know how they work, know how to communicate and ask questions. Insurance and benefits, this is a big thing that changes once you become an adult. Daily living personal care, which also changes very much so when you become an adult. And obviously, school, education, vocation, those kinds of things. Um, I like to tell patients that on their phone, they should have an updated medical summary. This is uh, essentially this is where the document that we are creating as time goes on in an ideal world should be made accessible to the family. This is not just for the providers. This is a shared document that what do we know so far and what happens in each different avenues of care here. So this is specifics, right? When a patient goes from the pediatric world to the adult world, what are things that can get missed? I'm going to say from experience, the actual genetic result gets lost all of the time. It was done 15, 20 years ago. It can be really hard to find it, and it matters when we think about what care looks like and what other options look like into the future. The exact medications, the full list, and the dosing, and what worked and what didn't work, and why. Who are the exact specialists? There are many people often involved. And the actual values, the baseline cardiac, like the echocardiogram values and the Holter monitoring and the MRIs and all of that, everything that's accessible, we should have in a way as public knowledge. And of course, the equipment needs. This information becomes really helpful in an emergency department that doesn't really have the luxury of time to go through all of the records in detail, all of the many years of records to figure out what's important from a respiratory perspective in this case. And also, frankly, an emergency department that does not see Duchenne muscular dystrophy every day is going to need a summary. Um, so there's first parent-led care, and then it should shift ideally to patient-led care. So um, these are all things that we've essentially talked about, but you understand what I mean at this point, where we should be setting the goals more and more and more and shifting the conversations more to the patient as able, if they're able to. There's a whole team behind every patient with Duchenne muscular dystrophy. Thank goodness that we are not acting in isolation. The the one of the members that is in a way almost like the team lead, not because they're the most important person in the room, but because they can keep everybody else in check and make sure that we're all working truly as a team, tends to be a neuromuscular neurologist or a neurologist more broadly. So they're in a way the coordinator of the big picture. Cardiologist, pulmonary, physical therapy, orthopedics, endocrinology, gastroenterology, and a care coordinator and social worker are all part of the team, but not for everybody. It depends on who is the patient. Now, the goal here is knowing who does what, which can be hard, and rebuilding it in adult care and transitioning it to adult care. So I'm going to go through, actually, it's almost a little tedious, but I do want to go through all of these different people. What do they do? What are they thinking of in the pediatric world? And what should they be thinking of or can they be thinking of as they transition? From the neuromuscular standpoint and bone health, I put them here because they kind of go hand in hand. Um, our questions that we really should be having is what's our long-term corticosteroid plan if we're on corticosteroids? Steroids are not the right answer for everybody, especially as someone gets older. How do we monitor and manage side effects? Which functional changes should prompt a call? Essentially guiding the patient to say, look, if you're having a certain issue, we want to hear about it. And how do newer DMD therapies apply to my son? So this is from a neuromuscular perspective where we have many different therapies that are in trials or that are now approved. They are not the right answer for everybody. They're not applicable to everybody. And so it's very individualized. We should be thinking of as we go from the pediatric to the adult world, what would we want the adult provider to know about? Because we have the whole story. We have years of experience already with the patient, and we know what is the right thing for them. And maybe we also know if they've been in trials, what have those looked like? From an endocrine perspective, we often forget about the downstream consequences of our many years of steroids, and we often forget, or we put to the side for later, the downstream consequences of not being as weight bearing as one would like, and the issues that can go to the bones with that, as well as to the hormone system as a whole. So we should plan to pass off what did bone density assessments look like, and when was the last one? These are things like a DEXA scan that I'm talking about, or X-rays. Um, are we watching for fractures? How are we doing that? Have we ever had issues with adrenal function, especially if we've been on long-term steroids, and has growth and puberty and all of those been affected, which often they are? And importantly, is there a stress dose steroid plan for illness or surgery? Patients who are on steroids long term should have a stress dose steroid plan, because when the body gets ill or when it gets stressed, may not be able to now produce its own steroids to sufficient quantities, and that might make your body's stress response not as robust as one would hope, and really cause a stressor to go far disproportionately out of whack to what you would expect. Here are just things that we look at specifically with steroids that we want to make sure this plan keeps going. So the benefits of steroids, I think we're familiar with at this point, is that they do prevent, or that they do prolong the ability to walk. Respiratory function, scoliosis are certainly affected in a good way. And then cardiac function, this is a big question mark of how much does it help the heart, and the overall decline. Now, what we monitor for is the growth effects of steroids, so that's weight, height, and BMI. Blood pressure and glucose, those are downstream consequences. Like I mentioned before, bone density and fracture risk. Steroids as a side effect can affect the bones, and often do. Cataracts are a big component of it, so ophthalmology evaluations, and then adrenal suppression. So that's a stress dose steroid plan. These are just a prettier way of showing this. And then we get into mobility therapy and nutrition. We have a lot of services or supports with PT and OT that happen in the pediatric world. Many of these are through school with an IEP or an individualized education plan, and that becomes something that changes with an adult. So we should really make a good plan with that. Stretching and contraction management, we should make sure to hand that off. What equipment will we need, and who funds it as an adult? The funding comes from a very different place once you become an adult. And then at this point, we're really talking extensively about upper limb function or arm function. How do we protect it as long as possible? From a nutrition perspective, we should be talking about dietitian, swallowing aspiration, weight, and constipation. How are those being managed? Now, how does it really happen? There are several different ways that one can transition and not transfer. We can continue with the pediatric neuromuscular team into adulthood, and that's institutional based. Like I said earlier, some people do see patients far, well into adulthood or even far into adulthood. There can be a pediatric and adult provider in the same institution, and that can make it actually easy to transition little by little, not to do one visit where it's with one and then the next where it's with another person. We can transfer, or I really should have said transition, from the pediatric team to a separate adult team. So this is from one institution to a totally different institution. And then the cardiology and the pulmonary and primary care and everybody else like that it follows the same pathway, where it can be in different institutions or in the same. But it's very important that the different team members actually know each other. Care is not as good when you have a pulmonologist who is 200 miles away at some esteemed institution, and everybody else is at a local institution or at a different esteemed institution, or you name it. People really should personally know each other and be comfortable working with each other because this is such a team sport to take care, to have good care of a patient with Duchenne muscular dystrophy. I'm going to hand things off now to Dr. Zelikovic.
So Dr. Kesselman did a great job kind of setting the stage, and I just want to preface this by saying there's not a one size fits all, and depending on which part of the country you're at, depending on the available resources you have, this will look different. I think it's really important to realize that this is one perspective, and I personally have trained at different institutions that have done things differently, and it's not to say that one is better or worse than the other, but these are things to talk about and see what's in your local community as well, and advocate for your clinics to potentially offer more. So, unlike pediatrics, where you have your parents helping you, in the adult world, we don't actually encourage that. A lot of our teenagers and young adults, we start to tell them, look, it's nice to have your parents here, but you are in charge of your own healthcare. You make your own decisions. You don't need your parents' permission for anything else. And it's not to say that the parents aren't important or not an integral part of the clinical team, but it does change legally what they're allowed to do and what you're allowed to do. So we can no longer call your parents on your behalf. You have to be the one picking up because you're an adult. Additionally, it's no longer a diagnosis. It's no longer a, what does this mean for my life? It is now, how do we optimize adulthood, right? We're no longer questioning, do you have Duchenne or not? Do you have ambulation abilities or not? But it's saying, how do you really improve your quality of life as an adult and really maintain that quality of life question to really provide the longest, fullest, most independent life as possible? Next slide. So cardiology is a really important feature of what we do in the neuromuscular clinic, which is why we're actually creating the first cardiovascular multidisciplinary Duchenne clinic that also has cardiologists embedded in our adult clinic, because we want to know how the heart's doing. When you are non-ambulatory, not sitting and not exercising and on steroids, and you have an underlying mutation in your dystrophin gene that causes Duchenne muscular dystrophy, the heart gets involved and is actually the number one cause of mortality long term. So it's really important to, one, keep an eye on it and to be ahead of it and treat it when it becomes a problem, because you may not feel symptoms, but your heart ultrasound or an echocardiogram can actually start showing signs, and a cardiac MRI can even show signs before that. And thankfully, working with our cardiologist, we are able to treat it, right? These are things that we can help with, we can modify, and there's a way to really help optimize. And even if you have worsening, there's a way we can get you back on a better track and to be able to have more ability to do exercise, to have be awake more, and kind of improve that quality of life as well. So it's really important to report these symptoms when you are seeing your multidisciplinary care clinic. And if you're not seeing a cardiologist yet, really ask your neurologist to refer you to one in their practice that feels comfortable with that. Next slide. Surveillance looks like echocardiograms. Cardiac MRIs are great, but they require you to be in an MRI. So for some young adults with Duchenne, they really don't like being in MRI, and some patients need anesthesia for that. So if it's feasible, it's great, but many sites don't do this routinely, but an echocardiogram can be really good. You really need to monitor the heart rhythm with an EKG and making sure that you're on the appropriate medical therapy for the Duchenne-related cardiomyopathy, which starts in the teenage years as well. Next slide. So what does surveillance look like across the lifespan? At diagnosis, which as Dr. Kessman kind of alluded to, we are diagnosing a lot earlier, both for newborn screening, also awareness, and also treatments. But you should get an echocardiogram and a cardiac MRI when feasible because of the limitations of the anesthesia and being able to sit still and tolerate it. Pediatric multidisciplinary clinics tend to do echo imaging at least once a year. And then once you get into your teenage years, we're much more vigilant about the cardiomyopathy or the heart starting to have issues. And many teenagers working with their cardiologists will start to treat the cardiomyopathy, both if they start having symptoms, but also potentially to prevent it. Those two medications are ACE inhibitors and ARBs. And then when they get to my clinic, majority of our patients tend to be on cardiac therapies already. And our job is to maintain it and tweak it so the heart of our Duchenne adults are working just as well into adulthood as they did in their pediatric clinics. Next slide. This is a really nice figure in terms of what we have as the recommended guidelines in terms of the diagnosis. And as you guys can see, they don't really mark the transition of care component of it, right? You have your ambulatory and early non-ambulatory age. Historically, this was in the pediatric clinics, and late non-ambulatory stage was in the adult clinics. However, with the exciting new therapies and gene therapy, we are starting to see young adults, late teens, early 20s, who are still ambulatory. And we're starting to push the early non-ambulatory into your 20s and 30s. So we have to shift from this model of saying adult patients with Duchenne are non-ambulatory, can't do much, we don't really need to take care of them, but really shifting that narrative and really refocusing on saying our adults with Duchenne can have an amazing quality of life. How do we help get them from a medical side to work on all the other stuff as well? So all of this framework is shifting as we're getting better treatments and therapies and understanding how to take care of our patients better. Next slide. Respiratory and sleep care almost as important as cardiovascular care because when you have muscle weakness, you're not able to support your diaphragm as well. So it's really important that you don't tire out your muscles. And many of our patients with Duchenne will go on to nighttime ventilatory support or breathing support to really help them maintain their strength. For some people, they view this as a failure. I actually view it as a preventative treatment. Similar to how we start cardiac medications when you don't necessarily have severe heart failure, we started earlier when you start to show signs of damage to the heart. We need to start thinking of respiratory and sleep care the same. If you're not able to sleep well and you're not getting good restorative sleep, you're not going to allow your muscles to heal and recover, and you need it even more so than the average person. So sleep medicine is very important, and a lot of these sleep medicine pulmonologists are actually neuromuscular trained as well. So they're actually the right ones who can help with both because there's a lot of overlap in that respiratory sleep care realm. Next slide. What does respiratory care look like? We do this test called a pulmonary function test. So we get worried when you can't fully breathe out and you are less than 60% of predicted. Peak cough flow is how strong your cough is to get it out. And then we look at nighttime versus daytime, right? There are certain features in muscular dystrophy that are only present at nighttime when you're sleeping and laying flat. And then there's also when you're in your chair or walking and you're not able to necessarily blow out the carbon dioxide that you need. So these are all things that we can work on in the adult clinics to be able to optimize how meaningful and how much energy you have for that day. And without doing the testing, we're actually not able to know if we can intervene or not. And that's why regular close monitoring, not just with your neurologist in the adult clinics, not just with your cardiologist, but also with your pulmonologist, will help tweak and optimize your clinical care to really give you the most energy and the most muscle health that we can possible. Next slide. So this is another figure that Dr. Kesselman added. It's fantastic. This just gives you a sense of your needs are going to change throughout your Duchenne journey. And this is also shifting based off treatments and what treatment you got and how early. So the idea is as you start to age, you're going to need a team that is going to not just follow guidelines, but individualize your care. Because it's really important that you're getting unique care to yourself. Because what happens if you don't have breathing issues? Should you be getting these all the time? No. But let's say you're not seeing anyone and you're coming and you're saying, hey, Dr. Z, I'm really tired. I'm in college right now. I'm really enjoying it, but I'm like falling asleep at my desk. And is there anything I can do about it? And there is, right? And that's when we kind of refer you to our pulmonologist, get a sleep study. Would you benefit from BiPAP? Are there other interventions we can do? Is weight loss something that can help you with respiratory monitoring and all of that? Because what happens if you lost 15 to 20 pounds and you release the pressure for the hypoventilation at nighttime, could that be the solution? So it's really important to have a complex multidisciplinary team that is able to take the guidelines, which I believe this one was in 2018, and adapt them, right? These are constantly changing, and we're very appreciative of all of the research and all the patients and families who've gone through the clinical trials to now have allowed us to change the natural history of this disease, which is really exciting as an adult provider because I get to rewrite the book with all of you. And I think that's what's really exciting in using these guidelines and tailoring them towards the individual patient. Next slide. So what does the respiratory ladder look like? When FVC gets around 60%, we need to help with lung volume recruitment. When peak cough flow is under 270 liters per minute, we need a cough assist. And when the FVC is under 50%, we really think about doing BiPAP or nighttime non-invasive ventilation. And when you're really having carbon dioxide levels that are elevated during the daytime and you're sleepy and tired, we really need to think about this as well. And again, these are what the pulmonologist will be doing at each clinic visit to assess how you're doing and where you're at. Next slide. Bone health, endocrine, and long-term steroids. Picking back off what Dr. Kesselman talked about, we really don't have a good sense of what steroids have done into your 40s and 50s and 60s. So we're still trying to figure that out. We also know that muscle loss affects bones as well. So it's really important because two things. One, bone fractures are very painful. So as a young adult with Duchenne, even if you're non-ambulatory and in a wheelchair, if you get a bad hip fracture, you're going to be in tremendous pain. And if there's a way we can prevent that and treat you from an endocrine perspective, that's something we can help improve your quality of life. As Dr. Kesselman mentioned as well, steroid plans are really important, and many hospitals don't know about this. When you go to a provider and you tell them you have Duchenne, the first thing they should be asking you, are you on steroids or not? What is your dose? Do you have a stress dose steroid plan? And if you don't have that, that could really lead to some bad outcomes, and that's something that's preventable and avoidable. Additionally, family planning is a thing we really don't talk about enough in Duchenne muscular dystrophy. Steroids affect puberty, growth, testosterone, and if you are interested in having a family and want to be in that conversation, that's something we need to think about and counsel you on as well. And that's where we're hoping to support our adult Duchenne patients in the Duchenne adult clinics. Next slide. This is another figure that Dr. Kesselman had shown. We look at calcium, vitamin D, we do DEXAs as he had mentioned. There are treatments that endocrinology has that are infusions that can be beneficial to help stabilize your bone. We also know that steroids sometimes can improve bones in different dosing frequencies, and then different steroid treatments like vamorolone can also help reduce the amount of bone effects that steroids have. So there's all these things that we can do to help prevent a fracture, and it's really important to have that specialist kind of embedded in your clinic if you can. Next slide. Emergencies, as Dr. Kesselman and I have alluded to, prior proper planning prevents poor performance. The 6 Ps of success that I learned in high school with my strength coach, really having it written down with you as an adult, maybe in your phone or on a piece of paper in your wallet, will allow you, in case of an emergency during flu season, having a really bad pneumonia, having a urinary infection, all these things are super important so that you're not having to scramble last minute and trying to get a hold of your neurologist at 2 a.m. in the morning when you're in the ER. Try and have it with you in multiple locations and always revisit this with your provider at least once a year. What steroids am I on? Should I be changing them? Should I be changing my steroid dosing plan? Anesthesia is also a really important thing because surgery is inevitable. Many people need it, whether it's for your spine, whether it's for your bones, or gallbladder, or stomach. So you really need to let them know and make sure they're aware that you have Duchenne muscular dystrophy because there are certain anesthetic agents that can actually cause you to have worsening muscle problems. And we, as neurologists, are happy to communicate that with your anesthesiologist. Airway and cardiac guidance as well. If you have cardiomyopathy, a long surgery may be really hard for your heart to tolerate. So they may have to kind of adapt and help you modify your surgery so that your heart can kind of tolerate it. Next slide. So red flags, so succinylcholine or depolarizing agents can cause this really bad muscle problem. Volatile anesthetics can do it. Opioids can be problematic, right? Because if you have baseline breathing issues or low volumes, it can really depress your ability to breathe, which is a really big problem as well. And recovery period, you really need to help support your heart and your lungs as you're getting better post-operatively, more than the average population. Next slide. You are much more than your Duchenne muscular dystrophy, right? You're an adult living an amazing life. We want to help you live it to its fullest. There are things that are adult specific problems that you will develop. And if you're taken care of in a pediatric clinic, you may not be able to have the right care for that. So, low mood and anxiety can come from a lot of different places. And there are adult providers who can kind of help you with that. Independence is an incredible opportunity to really determine your own life. My goal as an adult provider is to find things that you're able to be independent in. It may not mean that you can go to the bathroom alone. It may not mean that you can go pay your bills on your own. But finding small things within your life that allow you to feel independent is going to help your mood. It's going to help your excitement and to find things that you really enjoy. Relationships are key, both in your personal life, both in the Duchenne community and organizations like the Jet Foundation to continue meeting other people with Duchenne, with your parents, right? A healthy relationship with your parents where they're part of your care, but they're not doing all of your care for you. And you need the opportunity to really shine as an adult. And that's what a supportive neuromuscular adult clinic is going to allow you to do. Next slide. So, going into the practical side, all this sounds great and dandy, but why is this important? Why do we encourage all of our adults with Duchenne to focus on this? Legally, you are now your own decision maker. For many of you guys, when you were younger and your parents were interested in a clinical trial, when you were under 12, they didn't have to get your permission. When you were 12 to 18, they had to kind of get your approval, but at the end of the day, your parents were the decision makers. When you're 18 now and I say, hey, patient so and so, would you like to be part of this clinical trial that we're doing for this therapy? You can't look at your parents and be like, do I do it? Do I not? You're going to be the one making the decision. Obviously, your parents can stay involved, but it now becomes under you. And as we talk about that, what does that mean if, God forbid, something were to happen? Who's making medical decisions for you? Do you have a healthcare proxy? Do you have a power of attorney? What about guardianship? All these different things would be really important to have those discussions because we want to have this in place before it becomes emergent, because then that can be really problematic. And the other thing is, every patient's decision is going to be personalized. Your own values, where you come from, your religious and social context are all going to be part of this. And it's not to say that it's a one size fits all prescription that we have. It really is meaningfully tailored to your own desires and your own outcomes. And I think that's what adult clinics are really good at, is because we start encouraging you to really make it your own and take ownership of it. Next slide. How can this be supported? So you have your own decision makers, you can have a healthcare proxy, or you can have a guardianship, which is our last resort. My goal is to get as many of our patients making their own decisions as possible with the support of our clinical team. And that's, I think, is the ideal. Obviously, in real life, it's not always like that. Next slide. So as a child, you're on your parents' plan, you have family income, tend to be on Medicaid, you have children waivers, family waivers, and the parent or guardian decides. But as an adult, you only get to be on your parents' plan until 26. So there may be that bridge to get you to that point. But after that, you need to find potentially your own insurance. And there's the healthcare marketplace. If you have a job, it can be through your employer. You may be able to use SSI and your own income as resources. And potentially, the insurance question will be challenging as well. So that's why, you really want to get ahead of this. And thankfully, from 18 to 26, you're technically still able to be on your parents' insurance, but into your early 20s, you want to start thinking, what was going to be my insurance when I can no longer be on my parents? And as Dr. Kesselman had mentioned, unfortunately, you may want to stay with your institution or provider, but if they don't accept your insurance, you're going to have to transition to a different clinic. And if it has to be done abruptly, that may not be a transition of care, that may be a transfer of care, which we don't encourage. So looking ahead and trying to get ahead of it will allow you to slowly build up that transition and not have to suddenly transfer your care as well. Next slide. Independent living, personal care. So some of my adult patients with Duchenne want to do everything on their own. They have a home health aide that comes and helps them, but they're doing it mostly on their own. Some people have personal care attendants that help them with certain things like transfers, hygiene meals. Some people have really good home modifications and assistive technology, so they really need minimal help. Getting around in a city like New York is challenging, so our patients look for ways to get around. Are there public transportations? We've actually partnered with an adult with Duchenne who created a transportation company, so that we actually have, working with our team, we help provide transportation for our patients into our clinic as well. And then a social worker really helps navigate these resources, both on the local level, within your hospital system, and then also within the regional and national resources as well. So getting plugged into a clinical multidisciplinary team will hopefully continue the resources that will allow you to get all these benefits as well. Next slide. College is a goal that I encourage all of my adult Duchenne patients to have. It looks different for different people, and really understanding what you enjoy doing and matching it up with your ability level. And that is, again, a personalized decision because meaningful work can look very different for different patients in different environments. What you're able to do in New York City is probably different than what you're able to do in Indiana or California or Texas, both based off accommodations, but also on job markets. So it's really important to know, one, what you enjoy doing, whether that's digital, and how much ability you have, and kind of matching that to find something that brings meaning for you and allows you to really have an opportunity to feel valued and have routine in your life as well. Next slide. As an adult, you are the patient. We have to talk to you. Don't allow other people to intervene on your behalf. You need to do it. Your own records, your medical information, when questions are being asked, you're the one who can voice your opinion. You can change any recommendation. You also no longer have to do what the provider tells you. If you think that this certain treatment or trial is not the right one for you, then you have the right to say no. You're also allowed to get second opinions. You're allowed to say, I really appreciate and hear what you're saying, but what you're offering me is not aligning with my personal goals and my Duchenne muscular dystrophy goals. I really appreciate everything you've done for me. I'm going to go find someone who's willing to work with me and what I need to do. And you need to be treated as a person, not just a diagnosis, not just a disability, but how are you as a person and how do we improve your quality of life and make you live the best life that you can possible? Next slide. What are things to think about at your adult visits? How often should I be seeing my pulmonologist, my cardiologist? Who's organizing all my visits? Do I have to call and make all the appointments? Or do you do that as the neuromuscular provider? Do you have a coordinator? If I need to have a question between my clinical visits on my steroids, my breathing, who do I talk to? How do I get a hold of you? Is it through MyChart? Is it through email? I personally give my Duchenne patients my email because it helps to get things quicker than going through MyChart. When should I go to the ER? When should I call you to set up a quick clinical visit? How do we protect my goals? How do I find a social worker? Are there clinical trials for adults who are non-ambulatory? What about equipment? What about my wheelchair? All of these things are important questions to ask because these are things hopefully your clinical team will be able to help you with and really help improve your quality of life as well. Next slide. Transition checklist at a glance. Conversation usually starts, I usually say 15 or 16. Dr. Kesselman thinks 13 or 14. Either one is fine. You really need to have an updated medical summary. Really start learning about what treatments you're on, why you're on them, why are you on the steroids, why are you on the ACE inhibitor. Really completing the forms in terms of the HIPAA forms, the proxy, writing down who your adult neurologist is going to be, who your adult cardiologist is going to be, and pulmonary team. Ideally, it's all going to be in one institution in one visit But unfortunately, many clinics are not like that. So you just have to keep a log of where they're at and where their address is. Make sure that your appointments are booked and verify like a month or two before. Make sure you bring your summary and emergency plan to every visit. Setting up local emergency and primary care, especially if you're going to a site like New York, like if you live in New Jersey or Connecticut, if you're going an hour and a half to see a neuromuscular specialist in a neuromuscular clinic, having someone locally as well, that's your point person. And really setting up a goals. Like, what do you want to achieve during this visit? What do you want to achieve as part of your multidisciplinary care clinic in 3, 5, 10 years? What would your goals want to be? And how do we as a medical team help you achieve those goals at these visits? Next slide. We are trying to make this better. We know that there's a shortage of adult neuromuscular specialists who are interested and qualified to do this. We want to train more of us, and we want to get more people aware of it. We're trying to develop really good toolkits to take to your neurologists and neuromuscular people to make them aware of it. There's this new concept of really doing dual cross-sectional pediatric and adult care centers. Like Stanford actually has this, where the adult and pediatric patients are seen in the same clinic and the providers rotate. So you'll actually get to see both of them in the same clinic room as well. Starting the conversation early. It's really important because this is not something that happens in a year. This is a multi-year process, and it's unrealistic to expect a 17-year-old with Duchenne muscular dystrophy to figure it out all on one visit. It's really important for your physicians to talk and provide warm handoffs and really voicing your concerns, right? This is your experience, and it's going to be different for every patient. So if you're not having a good experience, communicate that in a really respectful way and say, "Hi, Dr. Zelikovich, I really appreciate everything you're doing for me. I'm really struggling with X, Y, and Z in part of my transition. How can we make this better?" And 99 out of 100 physicians will obviously try and help and make things better or point you in the direction to allow you to have someone who's more qualified to do it. Next slide. So, as an adult, we want to treat you like an adult. And adult clinics are much better at that. And that Dr. Kesselman can correct me if I'm wrong. We much we're much better at we will assist you, but you're the driver. You're in the driver's seat. We're going to be helpful, but at the end of the day, your parents aren't forcing you to come. We're not forcing you to come. You need to take ownership of your own care. You're going to be allowed to speak for yourself. It's going to be patient-led, not parent-led. You're making the final decisions. And at the end of the day, you need to be aware of all of the financial, medical, legal, and all the personal decisions that are going to make it important for you. And our job is to help support and elevate. It's not to dictate. And I think that's why I love the adult care model, is because we really let our adults with Duchenne really shine and really develop their own personality and really become their own person. And that's why I'm so appreciative to have the opportunity to be part of this and to really talk about this, to really empower all of you to become the best versions of yourself. Next slide. And these are our references. And thank you so much.
Well, thank you guys. I think, we have gotten a lot of comments on Facebook. This is such a needed topic. And like you said, this is something we're hearing a lot about in the space, right? Transition of care, not transfer of care. But as you said, there's a lot more transfer of care in the United States than there is in transition. So, I think that you guys are doing something really amazing. And like you said, we need more of you guys. So, thank you guys for this presentation. Thank you for all that you're doing. Thank you for trying to create change because that's not easy. So I will speak on behalf of myself and Jet Foundation. We really appreciate what you guys are doing. So with that, we will go ahead and open it up for Q&A. I haven't seen anything come through, but I will give it a minute. I am also looking at Facebook, haven't seen anything come through on there. But like I said, I know people are asking for the recording. I will send it once it's available. But we know that this is a lot and it also takes time to process. A lot of great information. If you do find any questions after the fact, please go ahead and send it to me. I did see one just come through. Are there any resources for parents when it comes to transition and transfer? Hopefully in the future, all transition of care.
So there are several resources, and one of them is what I actually brought up earlier, which is that there is um, a publicly available paper from 2018 by Dr. Trout that talks about this and creates that checklist. I think that that is something that we should highlight, as it's not really meant for, it's meant for everybody. It's meant for parents as well as for us to read up on and use as a checklist. Um, the if you go to another organization like even the PPMD, if you go into their own transition of care guidelines, it is literally that paper and that exact checklist. So that is something that I would urge you to go into. There's a growing body of um, urgently needed interest in this particular field that we're talking about transition of care from within Duchenne muscular dystrophy centered at parents and patients, and um, that is growing quickly, and that is right now really highlighted in webinars and meetings and things like this. That we don't have very much that is foundational and on paper, but that is something that we are actively working on. And Dr. Zelikovich and I have particular interests in this and are also actively working on ways to try to improve this whole process.
We also have found there are resources. GotTransition.org has good resources. University of Utah, we actually found some really great transition resources from them as well. So we'll make sure to share all of these in with the recording so that you guys have them. Um, because I think, I think there's a lot, kind of like Dr. Zelikovich said, right? He said 15 to 16. Dr. Kesselman says 12 to 13. So there are a lot of resources, but you can find what works for you, I think is my point, and what works for your family. And a lot of them have a lot of similar information, just maybe those age tweaks. So we will definitely share those with you. Any other questions?
The other thing to highlight on the
Yeah.
resources for parents, I think it's really important to be cognizant that every child is different. And some children will be ready at 13 and 14 to start the process. Some people, unfortunately, and Dr. Castleman actually published on this, there's different levels of cognitive impact in dystrophin. So you really have to tailor it towards your individual child and how they're doing. And some patients are ready at 12 and they're young adults, and other patients at 20 are still struggling to kind of do their own thing and maintain the cognitive demand needing to be independent, right? And that's where I think it's really important to tailor it. Obviously, it's a conversation, right? Like being realistic about your child instead of just saying, this is what the guidelines say, we need to do it. It's really a patient by patient approach with frameworks. And that your neurologist should be able to help you with as well.
It's a really good point. One more point, people are bringing up PJ's protocol, which yes, absolutely for stress dosing. That was just updated recently with vamorolone as well. So we will link to that as well. But I want to thank again you both for being here. Thank all of our participants today for watching. And again, if you have any questions, please send them my way and I will we'll try to get them answered. So thank you all again.
Thank
Have a
you.
great day, guys.
Thank you all. It's been a pleasure.
So the other thing before
Oh
we
yeah. Sorry, you were on mute.
sorry. I'm available via email if any family has any questions, nationally or locally. We're building a multidisciplinary clinic in New York City for adults with Duchenne muscular dystrophy. I know Dr. Kesselman is building a multidisciplinary clinic in Westchester as well. Obviously, there are a lot of great providers, but if there's anything we can do for your children or your young adults, we're happy to help and be part of our clinic or just help remotely as well. We hope to continue to be a resource for the Duchenne population, and our contact information will be part of the JET Foundation. They can provide you with our contact information.
Excellent. And that is a great plug. We will be having our a New York workshop, which more information will be coming out soon. We'll be doing 2 days. We'll be doing one day in White Plains and then another day in Harlem. So keep an eye out for that. And they will actually be presenting at that as well. So again, thank you both, and we will see you all very soon.
Awesome.
Have a great day,
You
guys.
all. Bye.
Bye bye.